right. Good evening, everyone. Thank you very much for spending some time and joining me this evening to talk about an issue that I take very seriously and hope to help my patients with, and that is erectile dysfunction, particularly erectile dysfunction that does not respond to some of our more conservative treatment options. So again, thank you all very much for spending some time with me this evening. Our agenda this evening is fairly straightforward. Overall, of course, the goal is to educate men, educate their partners about erectile dysfunction and about our various treatment options. Of course, we'll start with a brief introduction. We'll talk a little bit about what erectile dysfunction really is and what causes it. We'll talk about some of the issues that I'm sure a lot of guys attending this evening are familiar with in terms of dealing with ED. We'll transition at that point to talk more about treatment options, hear a little bit from the kind of patient perspective, and then at the end of the presentation, we'll have some time for questions and answers. I think now is as good of a time as any to say that everything here is nobody's personal information is available, quite frankly, to me or to anyone else who is participating. We do record these webinars and none of your information is available through the recording. And we stop the recording at the time of the question and answer period so that there's no concern there from a privacy standpoint. My name is Frederick. I go by Rick Taylor. I grew up here in Central Ohio, actually in Berwick on the east side of Columbus. Did my undergraduate work at Case Western Reserve up in Cleveland, and then came back home to Ohio State for medical school. I had the opportunity to do my 5 years of urology residency training at Rush Hospital in Chicago, where I had the opportunity to work with Dr. Larry Levine, who has for decades now and continues to be if not the world expert in erectile dysfunction and prosthetic surgery. Currently, I'm working with Central Ohio Urology Group and have been for the last 11 years. My main office is on the east side in Gahanna, although I do spend significant time as well in the greater Grove City area. As with many of my partners in our large urology group, I take care of a whole variety of urologic issues, including, of course, bladder-related issues, cancer issues, including prostate and bladder cancer. Of course, we all treat kidney stones, but my subspecialty, particularly as it pertains to procedural medicine, is with erectile dysfunction. And so a lot of my partners send me patients with whom they're having difficulty treating their erectile dysfunction because I'm able to offer more advanced therapies than some others are in town. This is the disclaimer saying that we're going to discuss some medical devices and that the discussion this evening is really a general discussion, although I'm sure some of the details will be familiar and relevant to all of you as individuals. I have to say this is a general overview kind of discussion, and any true medical decision making should take place in a one-on-one conversation between yourself and your physician. So let's talk about erectile dysfunction. What really is ED? Because I have this conversation, of course, with guys in the office all the time. And what I hear a lot is guys saying, I do fine. But what does that really mean? Because what a lot of times guys are talking about is they're able to get some degree of an erection. It will fill with blood to an extent. It will get sort of half-massed, if you will, but not strong enough for actual penetration, not strong enough for sexual intercourse. And I think it's also important to say that every guy and every couple are going to define sexual activity a little bit differently. And so if we're unable to proceed with what we define as sexual activity because of our erectile issues, that is erectile dysfunction. So this, of course, can include the total inability to achieve an erection. This can include the inability to sustain an erection, or an erection that sort of, if you will, kind of comes and goes, or leaves earlier than we want it to. This is, of course, a very common condition. These numbers are continually updated, and perhaps unsurprisingly, every time they're updated, the numbers get bigger. And that's in part because of population growth, but it is, quite frankly, also because of population aging. Erectile dysfunction can occur at any age. In my practice, of course, as a specialist in this, I see men in their 20s, even men in their late teens who have this condition. But most commonly, this is something that we develop in our 50s, 60s, 70s. And so that's really 30 million American men, which is, of course, a pretty enormous patient population. The classic teaching is that 50% of guys who are 50 years old are going to have erectile dysfunction. 60% of guys who are 60, 70% of guys who are 70. So although oftentimes in my office, guys are very uncomfortable and nervous, very understandably, to have these difficult conversations, one of the early things I like to emphasize is, if you're 54 years old and all of a sudden you're having problems, that actually puts you in the majority of guys your age. That's not necessarily comforting to hear that it's so common, but there is a lot of research and development, and therefore treatment options available, because it is such a common problem. So we talk about 50% of guys having ED. Well, guys will often ask me, how do I make sure that I'm in the sort of good 50%? How do I make sure I'm in the 50% of guys at age 50 and 40% of guys at age 60 who don't have erectile dysfunction? Well, there are ultimately, erectile dysfunction is a consequence of blood flow problems or nerve signaling problems. So normally at the time of an erection, we'll talk about this a little bit more in the slides to come, but blood vessels have to dilate in order to increase the amount of blood flow in the erectile chambers of the penis. And so anything that has a negative impact on our blood flow is going to have that kind of an impact on our erectile function. So oftentimes we talk about hypertension or high blood pressure. Sometimes that gets marketed, or guys hear of it as the silent killer. And the reason that we talk about it that way is that hypertension and also diabetes, as you can see on the list here, those conditions often don't cause any symptoms until they cause permanent dysfunction. And the reason for that is we can be walking around feeling pretty good, but if our blood pressure is just a little bit high, instead of 120 over 80, maybe it's 150 over 90, or 160 over 85. And very slowly, very gradually over time, what that does is cause damage to our blood vessels so that they don't dilate as well as they used to. Similarly, diabetes causes sugar that's in our bloodstream to be deposited, to sort of line the arteries, which decreases their ability to dilate normally, and sometimes has an impact on our nerve function, which is also necessary for the erections to occur normally. Depression is actually a common problem that causes ED, as are the medications that we often use to treat depression. And so here I always have to be very careful to say, if you are on a medication for diabetes or high blood pressure or depression or other forms of cardiovascular disease, we have to keep those medications going because they are crucially important for treating these other conditions, but they certainly can contribute to our erectile problems. Classic examples of this being blood pressure pills, particularly beta blockers, but also thiazide diuretics, things like hydrochlorothiazide or chlorthalidone are pretty classic medications that can give some trouble. Lifestyle issues have to be mentioned, of course. Stress can be a difficult thing for us all to manage, but certainly can be a contributing factor to erectile dysfunction. But alcohol abuse and smoking, these are the kinds of things that often we get into these habits on a daily basis and wake up one morning and it's been 30 years, and those things really can accumulate and cause problems over time. Sometimes things that we as urologists do to guys can cause problems, like treatment of benign prostate enlargement or prostate cancer can cause trouble with our erections. Any other surgeries in the pelvis, for example, guys who have had major colon or rectal surgery oftentimes will have trouble with their erections. And of course, sometimes there are psychological factors. In fact, I should say that differently. There are very commonly psychological factors, because who's happy with, erectile dysfunction? If we have difficulty at that moment, of course, there's going to be a psychological impact of that, and that just accumulates and makes things more difficult as time goes on. Of course, for the majority of guys, erectile dysfunction negatively impacts their everyday life. As a guy who has conversations with guys about this all the time, of course, some men just sort of look at the loss of their erections as, no different from a bum knee that just gives more trouble, and it's just something we have to live with. And if that's where we are in life, that's absolutely fine. I think it's important for guys to know that we don't necessarily have to treat erectile dysfunction, but we do have lots of options to do so for guys who would like to go in that direction. ED often does impact our self-confidence. There's a certain correlation with what we expect out of ourselves as men from the standpoint of our erectile function, and when that goes away or that's negatively impacted, obviously that's going to have an impact on us. Less frequent intercourse certainly can have some issues in terms of, again, our self-confidence, our interest and enjoyment in life, and of course can have potentially some impacts on our relationships. Loss of penile length is an often unspoken or untalked about consequence of erectile dysfunction. And so just to say a few words about it, when we're sleeping at nighttime, we are typically having 4 or 5 nocturnal erections, and often we wake up in the morning with an erection as well. And actually, before we start to have problems in the bedroom, we are unconsciously losing those nighttime and early morning erections. And when that happens, we gradually lose some penile length because of some atrophy of the erectile tissues of the penis. So it is very, dare I say, common for guys to lose some length when they develop erectile dysfunction. So I mentioned a couple of slides ago that what has to happen is blood vessels to dilate. So really the place that this starts is with some form of sexual desire, which causes nerves up in the brain to fire. Those nerves then send signals that travel down the spinal cord, ultimately terminating at the level of the arteries that carry blood into the penis. And what the nerves do is actually release a neurotransmitter called nitric oxide, which travels across a very small but very real physical distance. That nitric oxide then binds to the wall of the artery, causing the artery to dilate. As the artery dilates, that increases the blood flow into the 2 erectile chambers that you can see here depicted at number 2. And as those erectile chambers start to fill with blood, that causes the shape of the penis to change, but it also internally causes compression of what's called the dorsal vein. So depicted here, this blue structure that I've drawn an arrow to is the major vein that drains blood out of the penis. And as the erectile bodies fill with blood, they compress that vein. So in an ideal circumstance, we end up with a lot of blood flow going in and very little blood flow going out. And that's really what leads to the rigidity of the erection that we had when we were 25. One of the problems that we run into is if the erectile bodies don't fill with blood as strongly or as much as they used to, we may never compress that vein completely. And so although we're getting blood flow going in, we're also getting blood flow going out. And so we're never going to be able to maintain that rigidity, and we're going to lose the erection earlier than we want. So what do we do about erectile dysfunction? Guys who may be on the presentation tonight that I've seen in the office, can attest that we talk about some of these things that I've just gone over, certainly in less detail, just because we have less time in the office. But the real focus of the conversation, of course, is what do we do about this? It's great to know why it happens, but what can we do to fix it? Well, a lot of guys are familiar with medications, that is to say, oral drug therapy. And in 2022, and really for the last 20 years, 25 years or so, the cornerstone has been phosphodiesterase 5 or PDE5 inhibitor medications, of which there are several. Guys are familiar, of course, with Viagra and Cialis. Levitra, Stendra, and Staxin are a few others that have been on the market for years. The market's been dominated by Viagra and Cialis for decades now, and will, I think, continue to be for the foreseeable future because both of those medications are available generic. So we had a period of time in the 90s and 2000s where these medications were $30-$40 a pill. But now we live in a world where they are generic and are quite a bit less expensive than they used to be. So the way that the medications work is that they essentially keep the blood vessels dilated longer. Specifically, what they do is they keep that nitric oxide that I mentioned a moment ago is released by the nerves. They keep that nitric oxide from degrading, and the nitric oxide then tells the blood vessels to dilate or to stay dilated longer. So they don't work automatically. As I tell guys in the office sometimes, you can't just take a pill, sit back, and wait for the magic to happen. You got to be in a normal sexual environment. And very importantly, we got to have that nitric oxide, which means that we have to have intact nerves. So pills are often not great options for guys whose nerves are damaged. For example, guys who have had prostate, particularly prostate cancer surgery or radiation, guys who have had surgery or radiation for colon or rectal cancer, guys who have nerve dysfunction because of diabetes. Oftentimes, the pills don't work as well as we're hoping. In fact, in up to about 35 or 40% of all guys, they don't work super well. They do work best when they're taken on an empty stomach and in the absence of alcohol. So that's another negative impact, obviously, on our lifestyle. We can't go out for a nice dinner, pop a Viagra, and expect it to work as well as it would if our stomach was empty. There's a few things that Viagra or Cialis or the others might cause from a side effect standpoint. I mentioned that the medication helps to keep our blood vessels dilated. Well, it does that to some of the other blood vessels and smooth muscle in the body. So if we get blood vessel dilation to the head, we're going to get a headache. To the face, we're going to get facial flushing. We might get stomach upset because it relaxes something called the lower esophageal sphincter, which is what holds our stomach acid in place. So by upset stomach, we really mean things like acid reflux and heartburn. We might get muscle aches or back pain or nasal congestion as well. Oftentimes in my world, I'm talking to guys about penile injection therapy, which always sounds more overwhelming than it really is at first. But penile injection therapy is simply the idea of using a needle to deliver medication directly to the erectile bodies. As we can see depicted here, the needle is passed through the skin and directly into the erectile body. We do not have to get into a certain blood vessel or anything along those lines. We just have to make sure that the medication is delivered into the erectile body itself. The advantages of injection therapy is that it's more effective than pills. We don't need nerves to work for this medication to work because it just works locally. So there's no issues with absorption. We can use injection therapy with a full stomach. We can use injection therapy carefully, of course, as always, after a drink or two. We can use injection therapy if the pills are not effective and still have an expectation of success. And because it just works locally, the side effects are localized to the penis. So what are some of those things? Well, sometimes the medication works too well. And if that's the case, then we might have an erection that lasts for longer than 4 hours, which sounds amazing until we're about 2.5 hours in, and it starts to feel like if you put a tourniquet on your arm and held it there for 2.5 hours, you can imagine the pain that you might develop. So that can be a very uncomfortable circumstance. Absent the erection lasting longer than 4 hours, some guys do get discomfort with the medication, particularly certain types of medication. Some guys can get changes from the standpoint of skin irritation and numbness or itching, depending on kind of where the medication is injected. Sometimes we get a little bit of bruising. If we always give the injection in the same spot, then we might develop some fibrosis or scarring, which in the worst case can cause actually some curvature of the penis over the years of use. So this is something that we teach guys how to do in the office, and it really does require some teaching in order to move forward. It's not the kind of thing that we want guys to just borrow from their friends and give it a spin, shall we say, because the dosage is really quite specific and individual, as of course is the way of giving the injection. Vacuum pump is something that a few guys in my practice use on a regular basis. Vacuum pump is essentially an externally placed plastic cylinder that has a little rubber gasket here at the base that forms an airtight seal with the skin. Once that is over the penis, then there is a little pump that's either a hand-powered pump or, in this depiction, a battery-powered pump where we press a button and suction causes blood to fill the penis. The advantage of the vacuum pump, quite frankly, is that there's no needles or procedures involved. It just works locally there where we want it to work. And when it works consistently well for guys. The downsides of the vacuum pump are, first of all, the blood that comes into the penis with the vacuum pump is from the venous circulation, not from the arteries, and therefore the blood is cooler, and so the erection is cooler to touch. And that is sometimes bothersome for guys, or perhaps more commonly to their partners. It can be a little uncomfortable because once we fill the penis with blood, we have to trap that blood in place with the use of a constricting band. So actually what we typically do is place a constricting band around the cylinder of the vacuum pump. And then once we have the erection, we roll that down to the base of the penis to help hold the blood in place. That can be a little uncomfortable, and it can also impair ejaculation. Interestingly, the vacuum pump is the only treatment that has been shown to increase the length of the penis over time. As we talked about, there can be some loss of length with the development of ED, and regular vacuum pump use will often not get guys back to where they were before they started to lose length, but certainly can improve the length of the penis close to kind of where we were before developing trouble. Insertable drugs are fairly rarely used these days. In fact, it's been several months since I've prescribed it because the last time that I prescribed the medication, I was told by the pharmacy that it wasn't available and they weren't going to be ordering any. So sometimes we have some difficulty with these medications that aren't super commonly used. But a urethral suppository, or what's called Muse, is a little pellet that is placed in the tip of the penis with an applicator. So essentially, this applicator is placed in the tip of the penis, and then the pellet is passed through the applicator into the urethra. There is also a gel version of this medication that's available through some compounding pharmacies that we work with. That's a similar idea, but instead of a pellet, it's a gel that's placed in the tip. And then the medication is absorbed through the urethra tube to then act on the erectile bodies themselves. The real advantage of a urethral medication is that it doesn't have to be refrigerated. This is something I didn't mention about the injection therapy, but the injectable medications do need to be kept cold, ideally frozen, or at the very least for short periods of time, refrigerated. So they can be a little cumbersome to travel with, for example. I had a guy not too long ago, he and his wife go camping on kind of a private campground virtually every weekend in the summer. Well, a medication that needs to be kept frozen is going to be a problem, obviously, in that circumstance. So we have to come up with alternative solutions. The suppository or the gel do not have to be kept cold, so they're a little bit more convenient for travel, but they don't work quite as well, certainly, as the injectable medication. And so it's not something that we use just super commonly. Penile implant is another great option for a lot of guys, and really at the end of the day is the only restorative procedure or restorative treatment available to us for erectile dysfunction. Because as I like to say to guys in the office, once the implant is in, once it's healed, it's going to function consistently well each and every time. There's none of this business of taking a pill or doing a shot or using a pellet or getting out the vacuum pump and having the cumbersome time involved in those things, and the concern about whether it's going to actually work or not. Again, once it's in and guys know how to use it, it's going to function consistently well each and every time. So there are two types of penile implants, broadly speaking, that we place in the United States. The most common by far is what's depicted here, which is the inflatable penile prosthesis, which is composed of three different components. There are paired cylinders here, which are placed in the erectile bodies of the penis, one on each side. Those those cylinders are connected by some tubing to a pump, as depicted here, which goes in the scrotum in between the two testicles in a place that's very easy to find. I did a couple of these implants this afternoon, and I always take great care to make sure that the pump is in a place where we can easily feel it for future use. The pump is connected by a separate tubing to a reservoir, as depicted here, which goes in the groin area in a place that we can't feel it. And at rest, the reservoir is filled with sterile saline or saltwater solution so that the penis is normal in its flaccid state. That is to say, when the implant is deflated, I like to tell guys they can wear sweatpants to church. Nobody's going to know they have an implant in place. Guys could shower in the locker room. Nobody's going to know they have an implant in place because when deflated, the cylinders provide a natural flaccid appearance to the penis. It's a one-step deflation in the sense that we just squeeze a release valve as depicted here, which is part of the pump, and that deflates the implant. As I mentioned, it's totally concealed in the body, nothing external to the body, and it is really fundamentally a self-contained hydraulic system. So we never have to replace the fluid. The fluid simply goes from the reservoir into the cylinders for the erection and then back to the reservoir for flaccid everyday life. So this is a little video that kind of depicts the inflation and deflation of the inflatable penile prosthesis. So as we can see here, the implant is depicted in the description here. The reservoir is there in the groin area where guys can't feel it. The cylinders are there, deflated in the erectile bodies, and the pump is in the scrotum. And when we want to achieve the erection, what we simply do is squeeze the pump. The number of times that we have to squeeze the pump depends on the size of the implant, quite honestly, and how strongly we squeeze the pump. But as you can see, that causes the cylinders to inflate for the erection to occur. When we're ready for the erection to be done, we simply squeeze that release valve on the pump, often give a little bit of pressure to the cylinders themselves, and that causes the fluid to go backwards into the reservoir where it's stored for future use. Satisfaction rates for the implant are quite high. 98% of guys and 96% of their partners express satisfaction with the function of the implant. And I think the point of this is to say this is a natural result. In other words, it feels natural for guys. It feels natural for their partners. I think it's also important to say that the implant doesn't do anything positively or negatively about orgasm and ejaculation. As a totally separate issue, sometimes guys have some difficulty with orgasm and ejaculation as time goes on. The implant neither helps nor hurts with that. So if we were having normal orgasm and ejaculatory function before the implant, we would certainly expect that that would be the case afterwards as well. And sometimes if we were having challenges with orgasm and ejaculation, that may be because we're not able to maintain the erection long enough to reach that point. And if that's the case, then the prosthesis can help there as well. In addition to the inflatable implant, there is something called a malleable penile prosthesis. Malleable prosthesis is simply composed of cylinders that are placed in the erectile bodies of the penis. There's no pump, there's no reservoir, and we can see three different cylinders depicted here. And the reason that there are three cylinders is because there are three separate girth measurements or girth sizes that we can choose from in the operating room when we place one of these implants. The malleable implant has the advantage that there are there's no fluid, there are no parts or pieces that can break. So once the malleable prosthesis is in place, it's going to function well in perpetuity. But essentially with a malleable implant, we have the same length and rigidity all the time, but the malleable implant bends. So it bends down for everyday life and it bends up for sexual activity. So it's very easy to activate and is the prosthesis of choice for guys who have some issues with hand strength or dexterity because there's no pump that we need to squeeze in order to achieve the erection. Again, it's completely contained within the body. And really the major disadvantage is that it does stay firm when it's not in the erect position. There are a handful of scenarios where the malleable is the preferred prosthesis. We talked about issues related to hand strength or function. Also, quite frankly, for guys who have lost significant enough length that they have difficulty with urination. Sometimes we lose so much erectile length or penile length that the penis actually telescopes into the body, which is obviously a very distressing thing to occur just in general, but also can be difficult from a hygiene standpoint, from a urinary perspective and that sort of thing. And in that case, the malleable is a really perfect solution to help bring the penis back out from the body in order to help with urination and, dare I say, everyday life. There are, of course, risks of the penile implant procedure, as there would be risks of any procedure. This does require a trip to the operating room. The approaches are slightly different. Typically, for the inflatable prosthesis, I make an opening in the skin that's about, an inch and a half or so in length, and make that opening in the skin about an inch above where the penis hits the belly. But anytime we make an opening in the skin, there are risks of bleeding and infection. Bleeding risk with either one of these implant types is extraordinarily uncommon. It's very normal for guys to have some swelling and bruising for a week or two afterwards. But concerning or serious bleeding is extraordinarily uncommon and should not be expected. Infection is also extraordinarily rare. Less than 0.5% of guys are going to develop a penile implant infection. But of course, if that occurs, it's a big deal. If we develop an implant infection, sometimes it may require surgery to actually remove the implant in order to get guys over that infection. Again, extraordinarily rare, as I mentioned, less than 0.5% of the time. And we keep it that low by giving guys antibiotics during the procedure, by coating the implant with antibiotics. I prescribe antibiotic pills for a few days post-operatively. And I think it's very important to say that for my guys who have diabetes, we want their sugar to be under the tightest control possible. So we always check hemoglobin A1Cs prior to going to the operating room to make sure that the sugar is within, dare I say, an acceptable level. This says that it may make latent natural erections as well as other treatment options impossible. What does that really mean? What it means is that we wouldn't be going to a penile implant if it wasn't a necessary procedure to begin with. And so once the implant is in and in place, that's going to be the way that we achieve erections in the future. There is a certain, as we talk about at the bottom of this list here, mechanical failure rate for the inflatable prosthesis. As you saw in the video a few slides ago, that fluid moves from the reservoir through some tubing and into the cylinders. And if, as a consequence of normal life, a small crack might develop somewhere, particularly in the tubing itself, that might cause the fluid that powers the implant to gradually leak out over time. If that happens, it's actually not a harmful thing at all. It's important to say that the fluid is just saline or sterile saltwater solution. There's no silicone in the implant that would go to other tissues or parts of the body or anything along those lines. But the consequence of this is that one day we might squeeze the pump and nothing happens. And if that's the case, then we have what we in the business call a mechanical failure. And the only way to fix that problem would be to remove the old implant and place a new one, which is a routine procedure that we would do. Erosion is the idea of wearing away of some tissue next to the implant. This is something that's a little bit more common actually with the malleable implant because it is a fixed length and rigidity. So a little bit more possible that the malleable implant could cause some erosion into the tip of the penis or even into the urethra tube itself. Migration or unwanted movement of the device within the body. Really the only scenario that I've actually seen that occur in my 17 years of experience is if the tip of a cylinder might migrate inside the erectile body itself. So we're not talking about, all of a sudden we wake up and the implant's in our shoulder or something really off the wall like that. But locally, there can be some shifting in very rare circumstances. Chronic pain, also fortunately extraordinarily rare. Obviously, this is a particular part of the body that gets a lot of good nerve supply and is very sensitive. But even less commonly than infection would we encounter chronic pain. And if that's the case, there are often medications, not pain medications, but medications that we can use to help manage that situation. Insurance coverage for implants actually quite good. The implant, whether it's inflatable or malleable, is covered very well by Medicare, also covered very well by private insurance. And of course, whenever I schedule any procedure for a guy, we pre-authorize the procedure through the insurance. So that's a routine part of the pre-operative process. 2 or 3 times a year, a guy's insurance will refuse to cover the implant. And often at that point, all that's required is a letter on my behalf. And then we're able to move forward in the vast majority of cases. I don't know if anybody on the presentation this evening is a patient over at the Veterans Administration Hospital or with the VA group of urologists, but the VA also does cover the implant procedure with the appropriate authorization through the VA team, which is a fairly routine thing for us to do as well. So at this point, I'd like to kind of pause my comments and turn it over to Stan and Teresa to say a few words kind of about their experience with the implant. And from there, we'll kind of move on to some conclusions and then questions as they may arise.
Hi, my name is Stan Rydelic, and I'm 61 years old, and I live in South Carolina.
I'm Teresa Rydelic. I'm 60 years old, and I met this gentleman when I was 15 years old, and we've been together ever since.
I've been married to my wife, Teresa, we've been debating this, 39 years. 39 years. 39 years of bliss. About three and a half years ago, I ended up getting ill. I thought I had the flu. It turned out that I had complete liver failure, and so unfortunately, or fortunately, I had to have a liver transplant. As part of the procedure to nourish my liver, I found out what they did is they rerouted some of my blood flow, and so I ended up with a condition called arterial insufficiency, which basically means that the lower part of my body had insufficient blood flow. After I had my liver transplant and I was feeling well again, and then I found out that things were not happening romantically. It was kind of a surprise. So what I did was I asked my general practitioner, and so he immediately says, well, you know what? All you need is some Viagra. So what he did was he gave me a prescription for Viagra. I went home. I remember that evening, I was thinking, oh, how wonderful, Viagra. Of course, it's going to be a great evening. So what I did is I put some music on, poured some wine for my wife, lit some candles, and guess what? Nothing happened. So I went back, and and every time we're going in, it's just like it's 2 weeks or so between appointments, and it's still like nothing's happening, and you start to really get very discouraged. So the doctor gave me a choice. He says we could use vacuum erection devices, he says, or we can also use an injection. So I said, well, let's try the vacuum thing first. That was horrifying. Well, first of all, in my opinion, it was horrifying. It didn't really work. So that was like a one-time shot. And then we tried it was Trimix that I tried. And so I thought that was going to be great. Went home, and again, since there was a tiny bit of success, I thought this was going to be a great evening. So you try to get all romantic, and then you say, oh, excuse me, honey, I have to go into the bathroom and inject my penis with Trimix. I did everything that I could, and quite honestly, I had never even heard of a penile implant. And so when this doctor I went to, he was a young gun, kind of like, cutting edge, and he says, I think the only thing that we could do, he says, to really guarantee that you can get an erection is a penile implant. So Teresa was a part of the process. She came to the doctor's office with me, and what we did is we had the discussion about it in penile implant, and she said, look, if it means that much to you, she goes, I want you back how you were. I want you happy. a couple things came up. The first one that I worried about was the procedure a painful procedure? And quite honestly, I was told, and after experiencing it, it's an outpatient procedure. It takes less than an hour, in many cases a half an hour or less. Another thing that concerned me also, and this one's going to sound really, really very strange, but I really worried that I would have the desire to have sex.
Well, it's kind of ironic because that's exactly how I felt. I felt like, well, he's going to get this implant. We hadn't had sex in so long. Maybe that chapter's over. And I think that a lot of women worry that they're not going to be ready for this new adventure like they were. And it actually has been a renewal of our relationship in one area. And so I'm glad. I'm just glad it's freeing. It's taken on where we can be spontaneous, just so different than years before.
There was a romance.
Yeah.
There was a spark that was put back that we didn't know went out. The thing that's really, I think, been wonderful with an implant, with the implant, which I honestly, I don't consider I have an implant anymore. It's just, it's a part of me.
Right.
There's no, well, first of all, from the standpoint, if you look at me, if you saw me in the shower or whatever, you cannot tell that I've had an implant at all. And then also from the other standpoint is you have complete spontaneity. There is never anything where you have to say, okay, you know what, I'm going to take a pill and wait a half an hour for it to happen. If you're in the mood, you're in the mood.
Right.
And you know, I mean, it turns back the clock. I mean, I honestly feel like we're in our 20s or 30s.
Since the implant, there's a confidence there that is actually very sexy. And that confidence is something that I think the implant did for us. And I don't worry that it was me, that maybe I wasn't something that he was needing. No, we're perfect for one another, and now we have back our love life. If I could give some advice to someone dealing with this, a couple dealing with this, I would say talk to one another, be honest and open and loving, because the answer may be no. The answer may be, no, I don't want to do this, and it may be, I've been thinking about this. So I think communication is the key.
If I could give a piece of advice to anyone suffering from erectile dysfunction, it is the fact that you have one life and you have the choice to choose how you live your life and at what level of quality you live your life. So if you're suffering with something like erectile dysfunction, that's fine, you can live with it, but you don't have to. It's something that is so easily fixed, and you could have the quality back in your life that makes you a whole person again.
Well, that was great. And I heard a lot from both of them that I hear regularly in my office, pre and of course post-operatively, because the anxiety that comes with trying all of these different things that have spotty success rates. The depression, quite frankly, that oftentimes comes with all of that. I think we heard that from Stan, kind of from the preoperative perspective, and then kind of the satisfaction afterwards. And again, I think they both made a great point that I think we talked about earlier in the presentation, and that is for some guys and for some couples, the development of erectile dysfunction does mean the end of a chapter in their lives. And if the decision is that that's where we want to be, that is, of course, 100% fine. But I think the take home today is that we do have options that are very successful, kind of beyond what we're all seeing on television in terms of ads for Viagra and Cialis. All right, great. This last slide, just a little overview on how to learn more about the Prosthesis Coloplast, menshealth.com for guys for whom Spanish is their primary language, labombita.com. We'll get you all the information that you're looking for. And then there's my contact information as well for any appointments or anything along those lines. Obviously, if you are already a patient of one of my partners, please feel free and would be encouraged to bring this discussion up with them about proceeding in the direction that you think is most appropriate. And of course, I'm happy to see guys anytime as well. So thank you all very much. Finally, here is a little QR code. If you guys are familiar with this, you can use your camera to focus on this QR code here. And what happens essentially is that will take you directly to the website by just simply scanning that. We might be familiar with this for the absence of menus in restaurants since COVID, and everybody's got their menu on a QR code. But in any event, that will also take you to the same information and to an ED self-assessment to get a sense of kind of how things are coming along and what our options might be. Thank you all very much again. Hope you have a great evening, and please don't hesitate to reach out for any needs or for treatment options. Thank you so much.